So here I'm going to talk to you about nutritional requirements of post-renal transplant patients. Right, so if you have a look at this slide, the slide is showing you the journey of a CKD patient from dialysis dependency to a self-dependent life. Here you can see the patient is vomiting. This is a regular thing that we see in pre-dialysis patients or even in dialysis patients. The patient says he doesn't want to eat because they have lost their appetite and the taste of the food, and also the smell. They do not like the smell of the food, so they just want to stay away from food. And here is the patient on dialysis. Now what happens is when the patient gets a new graft, here is the new graft, and this is a patient who is like transiting to a better life. So a successful renal transplantation reverses uremic factors associated to malnutrition of dialysis phase. And here you can see the patient who was not eating very well during the pre-transplant period, that is during dialysis period, has an improved appetite and has started and is showing a drastic change in food intake and in the physical activity level also. But also have a look at these two patients where, they are so cachexic, so undernourished. On the other hand, when the patient starts eating very well after post-transplant, this is what happens to the patient. He starts gaining weight. And that's what we're going to discuss today. But the other side of the story is that there are several nutritional challenges because of side effects of immunosuppressive medications and metabolic abnormalities, which impact on long-term morbidity and quality of life of a kidney transplant recipient. So if you have a look at this table is showing you the nutritional challenges because of side effects of immunosuppressive medications. So you have our patients do keep complaining about diarrhea, which is because of everolimus, MMF and tacrolimus, gastrointestinal discomfort because of MMF, then hyperglycemia because of cyclosporine, everolimus, prednisolone, sirolimus, tacrolimus, hyperkalemia because of cyclosporine and tacrolimus, hyperlipidemia because of cyclosporine, everolimus, and all other immunosuppressive drugs, then hyperphagia because of prednisolone, that's steroids, then hypertension because of cyclosporine and tacrolimus, hyperuricemia because of cyclosporine, hypomagnesemia because of cyclosporine, everolimus, sirolimus, and tacrolimus, and increased catabolism because of steroid therapy. And of course, nausea because of azathioprine, cyclosporine, mycophenolate, and tacrolimus. So good nutrition actually plays a key role in successfully recovering from kidney transplantation. After any surgery, you know that adequate calories and proteins have to be given to the patients for proper wound healing. Okay. So good nutrition plays a key role in successfully recovering from kidney transplantation. After any surgery, we know that we do have to give adequate calories and proteins to the patient for proper wound healing. And also possible side effects of the anti-rejection medications can increase nutrient requirement, and a correct dietary approach can preserve graft, delay progression of both chronic allograft nephropathy and cardiovascular disease. So the goals of nutritional intervention are to improve nutritional status, to preserve graft function, to prevent weight gain, hyperglycemia, hypercholesterolemia, and CVD and metabolic syndrome. Now, the post-renal transplant is a very special condition which is divided into three phases: the early phase, the middle phase, and the late phase. The early phase is first month post-transplant surgery, that is day 0 to day 30. After the first month, the second phase starts, that is second phase, second month and the third month, that is day 31 to day 90. And after the third month, that is fourth month onwards, that is day 91 onwards, the maintenance phase starts. And in case later on the patient goes into graft failure, then we call him as, he's got into chronic renal allograft injury, that is CRI, which is like going back to the pre-transplant days, that is the patient is in the pre-dialysis period, so that he'll be having, he'll have to go through the whole thing again of low protein diet and stuff like that. So protein catabolism is the hallmark of early phase, and the factors which cause protein catabolism in the early phase are surgical trauma, short-term starvation, that is muscle abnormalities include low protein, change water content and amino acid concentration, and pre-existing protein energy malnutrition of the dialysis period, because dialysis is usually a prolonged period for patients, so they tend to become very, very weak. And then high dose of steroid therapy for treating acute rejection episodes and delayed graft function also cause protein catabolism, and the patient can also lose significant amount of weight. As the major nutritional challenges demanding attention after transplant are pre-existing malnutrition, protein hypercatabolism, new onset diabetes after transplantation, that is no doubt, hypertension, hypophosphatemia. Now we're not going to talk about hyperphosphatemia, which I spoke to you about in pre-dialysis and the dialysis period. We are talking about hypophosphatemia, hypomagnesemia, dyslipidemia, post-transplant bone disease, obesity, malabsorption, chronic allograft nephropathy or CRY, as we call it now, and anemia. Now, many of these factors contribute to accelerated atherosclerosis and consequent CVD. If you have a look at this paper, it is saying that there are only sparse guidelines for post-transplant malnutrition and adverse outcomes. So I'm going to concentrate on CARI, that is Australian guidelines, and guidelines from New South Wales Renal Services Network Transplant Working Group, and I'll be referring to KDICO guidelines, American Heart Association and American Diabetic Association guidelines also. That is usual for us. So the basics of a post-transplant diet is that patients should be put on a low salt, high fiber diet. The density of fiber in diet increases with fresh fruits, vegetables, and whole grains pulses, and this is to keep the cholesterol levels down. Then lean meats can be given to the patient, reduced fat dairy products, because we do not want to give them high cholesterol or saturated fats. And eggs should be given to the patients because eggs are the best friend of our CKD patients. But if the patient's lipid profile is fine, then he should not be given more than 3 yolks per week. Egg white is a very good substitute for a very high class protein, and they have to be taking plenty of water to prevent ATN. Now, guidelines recommend a regular nutritional assessment of the patient, and this has to be done by a dietitian. So we have to refer the patient to the dietitian, provided she is a renal dietitian. Renal specific dietitians, renal dietitians are trained into renal dietetics. These patients cannot be handled by a general dietitian. Okay, so we should know that whenever you get into practice, and if you are a nephrologist, then you must make sure that you train your dietitian very well, so that she can actually handle not only the CKD but the comorbidities as well, along with the CKD. So the responsibility of a dietitian is to do a dietary intake assessment, to do an anthropometric assessment, which should include the BMI, the waist circumference, the body fat estimations, and of course BIA or DEXA has to be done, but DEXA is not available everywhere. But BIA is a bedside tool. It's pretty affordable, so one can use it. Total body nitrogen should be done, but it is not done here in India. We are not doing it anyways. Then SGS scores have to be done. That is subjective global assessment. I'll be talking about this later on. The biochemical and clinical assessment has to be done by a dietitian, and the medication review also, whether the patient is taking the kind of medication that has been prescribed to him or not. And individualized verbal written advice has to be given by a dietitian for preventing post-transplant health complications and weight gain. Now, if you have a look at this table, this figure is showing you about the nutrient intake of post-transplant periods. Now, I'm not talking about the first 48 hours post-surgery, where we do a lot of IV replacement because the patient goes into diuresis. All right, so here we're talking about the month, the first month, the second and the fourth month, the fifth month onwards, that is phase 3, and eventually the CRY, that is graft failure. So a patient who's just had a surgery, just had a graft, requires a high protein diet, that is 1.3 to 1.5 grams per kg body weight per day of protein. And after 1 month, when you see the patient is recovered very well, he's not weak, then you move him from 1.3 or 1.5 grams of protein per kg body weight per day of protein to a lower protein intake, that is 1 gram per kg body weight per day of protein. And then after he's finished 4 months of his post-transplant period, then you put him on maintenance diet. That is fifth month onwards, you put him on zero 0.8 grams per kg body weight per day of protein. Now, for a CKD patient, a pre-dialysis patient, it's 0.6 grams, but here this is 0.8 grams because 0.8 grams is what per kg body weight per day is what is meant for a normal healthy individuals. And here we have a patient, even a post-transplant patient is a CKD patient, but because he's on steroids, so he requires throughout he's going to have protein catabolism. So we need to give him, protein intake, which will neither damage his graft, nor will he be losing muscle mass. Our main concern is to maintain muscle mass in order to maintain a good nutritional status. Now, if the patient goes into graft failure later on, after about a year or 2 years or 5 years, then he goes into the pre-dialysis phase, that is a low protein diet, but we still are going to give him something like 0.6 to 0.75 grams per kg body weight per day of protein, depending upon his nutritional status. Now, energy intake during the first month has to be high, that is 35 to 40 kilocalories per kg body weight per day. However, if the patient develops NODAD, that is a new onset diabetes after transplantation, then we have to be careful with how much calories we are pumping into this patient. The calories have to be brought down to 30 kilocalories. And along with this, one has to start insulin therapy, which normally is started in the kidney transplant unit itself. Now, fat, we do not want to give our patients a lot of fat because our patients have a tendency towards cardiovascular disease. And so you have to keep the fat content low. So 20 to 30 grams of fat, that is the visible fat that you put in the while cooking. Fat is of two types, the visible and the invisible one. The invisible is something that comes naturally with food, but visible is something that you add to the cooking. So visible fat should not exceed 30 grams in any case. Normally, the dietitians here prescribe 20 grams of fat, which is about 600 grams of 600 ml of oil per month. So remember, 600 ml of oil per month is a good target for your patients. And cholesterol has to be less than 200 milligrams per day. Sodium intake, because of hypertension, has to be less than 2 or less than 2 grams per day. Potassium intake will be liberal in this case because our patients go into diuresis. So we are not going to restrict potassium until and unless the patients do get hyperkalemia, which is drug induced, which is because of cyclosporine or tacrolimus. Then in that case, we'll restrict potassium to 3,500 milligrams per day. Now, fluid intake will have to be liberal because we, first of all, soon after the transplant, the patient goes into diuresis and he's making about 10 liters, 11 liters or even more of urine. So we have to replace fluid with IV infusions. And otherwise also, once the patient becomes stable and his graft is functioning very well, then we tell him to take liberal fluid intake. But later on, once he becomes really stable and we see that the graft is functioning very well, then after the second month or the third month or the fourth month, we tell the patient to restrict fluid intake to between 3 to 4 liters and nothing below 2 liters at all in order to prevent ATN. And actually, the fluid intake should be thirst driven. In a lot of papers, you'll find that it should be thirst driven, but the thirst driven should be nothing beyond, like our patients, some of the patients are taking 5 liters or 6 liters of water, which is really wrong. You're making your nephrons work over time, and that is not really good. So it should be thirst driven, but nothing below 2 liters in any case. But if the patient is got graft failure, then we have to restrict fluid, and we will not tell him to take 3 liters or 4 liters. Then we will actually restrict him to be taking 800 to 1,000 milligrams of 2 liters of fluid. Excuse me. Right. Now, phosphorus intake in the first month of post-transplant, the patient can go into hyperphosphatemia. So in this case, you will have to supplement phosphorus through diet as well as IV. And otherwise, later on, once the patient has stabilized, the phosphorus intake is normal. That is whatever is normal for a normal healthy being. But if the patient goes into cry, and that is he's having graft failure, then phosphorus intake will have to be reduced to 800 to 1000 milligrams per day. Calcium intake, we cannot exceed 2 grams in any case because of soft tissue calcification, because we do fear these things do happen. So we would rather restrict our patient between 1200 to 1500 milligrams of calcium every day, and particularly if the patient is on vitamin D analogs. And if the patient has cry, that is graft failure, then he will have to be put on phosphate binder. As you already have heard my lecture, what happens during the pre-dialysis and during the dialysis period. Magnesium, the patients can have hypomagnesemia because of cyclosporine and tacrolimus, so we will have to supplement magnesium. But if the patient goes into graft failure, then we'll be worried about metabolic acidosis. Then in that case, we'll have to supplement soda bicarb. Now, after transplantation, there is general improvement in all eating behavior. The eating curve is more linear after transplantation because of high doses of steroids, resolution of uremic symptoms with the good functioning graft, suppression of leptin synthesis, increased biodegradation of leptin by the graft and or reduction in fat mass, and near normalization of renal function also normalizes hyperleptinemia. So this particular study is showing that after transplantation, patients crave for carbohydrates. That is a corticosteroid-induced carbohydrate preference, which of course you do not tell your patients not to eat very well. We are very, very happy if the patient is eating very well. And now potassium intake is liberal if the urine output is more than 45 liters, and therefore the fruits are not restricted. However, if the patient is going into tacrolimus-induced hyperkalemia, then we'll have to restrict fruits and vegetables and raw salads. Now, moving on to hyperphosphatemia, this study is showing you that elevated fibroblast growth factors 23 levels as a cause of early post-renal transplant hyperphosphatemia. So hyperphosphatemia can persist after high parathyroid hormone levels normalize. The calcitriol levels remain inappropriately low in some of our patients after transplantation. But FGF23 levels decrease dramatically after renal transplantation, and during the early post-renal transplant period, the phosphorus rapidly decreases, suggesting that FGF23 is cleared by the kidney, but residual FGF23 may contribute to post-renal transplant hyperphosphatemia. And also, tacrolimus-treated patients exhibit significantly faster recovery from tubular phosphate reabsorption impairment compared to cyclosporine-treated recipients. Amelioration of phosphate handling in spite of hyperparathyroidism intensity can follow early steroid avoidance. So if the patient has hyperphosphatemia, you have to supplement patient with phosphorus 200 to 50 to 500 milligrams TID. If hyperphosphatemia persists, despite, this is hypophosphatemia, not hyper, okay, despite adequate dietary intake. So you can always advise your patients to take phosphorus-rich foods. And what are phosphorus-rich foods? Proteins are the carriers of good content of phosphorus. So they are milk, cheese, yogurt, poultry, and colas. Food, and now see, colas were not allowed to our patients when they were in pre-dialysis or in a dialysis situation, because colas contain a lot of additive as phosphorus, and we were worried about hyperphosphatemia. But here in the post-transplant scenario, we're not worried about hyperphosphatemia. So you can allow your patients to take colas once in a while. And you can always tell them to take foods with high phosphorus to protein ratio. And the post-renal transplant bone disease has specific presentation as persistent hyperphosphatemia in the form of osteomalacia or osteodystrophy. So in immediate post-kidney transplant period, a rapid decline in bone mineral density can occur because of high immunosuppressive doses and may continue during first 2 years. So calcium deficiency, low weight, low body mass index, and low vitamin D levels correlate with the bone mineral density and reflect poor nutritional status. So for transplant bone disease, the recommendations are, so far, no published data are present on the role of diet per se in preventing and managing bone mineral disease. But in patients in patients in the weekly until parathyroid function has stabilized. Now, KTRs, kidney transplant recipients, are advised to consume adequate diet to meet recommended dietary intake for age and sex with respect to calcium, that is 1,000 to up to 1,300 milligrams per day, and vitamin D about 5 to 15 micrograms per day. Intervention with vitamin D analogs or with calcium or bisphosphonates are effective in preventing bone loss. Now, coming on to fluid intake, I've already said that fluid intake should be thirst driven. At least 2 liters of fluid should be taken by the patients to prevent ATN. Boiled water is the best choice. And for how long do you boil this water? You boil this water for 10 minutes and then keep it covered so that it doesn't get contaminated. I'll be talking about contamination also later on to prevent foodborne diseases. Now, illnesses, sorry. Now, limit intake of high sugar, like regular soda or sweet tea beverages in these patients, and sports and energy beverages should be avoided in these patients. And excessive intake of herbal tea can interfere with cyclosporin levels. So therefore, the latest fad of green tea and other things should be controlled in our patients. Now, this table is showing you how we regularly monitor the graft function and the nutritional status for this. The weight, BMI, MUAC, blood pressure, blood sugar have to be done routinely. Hemoglobin, serum creatinine, serum albumin, and the total albumins have to be total proteins have to be done routinely. Then sodium, potassium, and serum cholesterol. These have to be done routinely, and dietary recall should be done by the dietitian, and anthropometry should be practiced as per the local protocol. As I said, DEXA is not available everywhere, but the guidelines for preventing MBD are say that, well, DEXA should be used routinely in our patients at least once in a year. And this is again the same chart which is talking about serum albumin, pre-albumin, and cholesterol. Cholesterol should be monitored and subjective global assessment should be done periodically to assess protein energy wasting. If it is setting in, then serum phosphorus and calcium should be measured to prevent bone disease, and lipid profile should be done regularly to prevent cardiovascular diseases. I mean, to monitor cardiovascular diseases, of course, and anthropometry, of course, to prevent malnutrition and cardiovascular disease and obesity. Okay. Now, blood sugar should be monitored 6 times a day in patients who have no DAT or who are actually diabetic from pre-transplant period. And it should be done as fasting pre-lunch and pre-dinner and postprandial 3 times a day. And Dr. Vijay Lakshmi Bhatia has yesterday very explicitly spoken to you about the insulin and about the diabetic diet. So I am going to skip that part. And I also in my previous lecture did talk about how to control hyperglycemia and how to control hypoglycemia. So patients on tacrolimus should abstain from taking grapefruit juice because this can alter the trough levels of the patient. Now moving on to hypomagnesemia. Tacrolimus or cyclosporin-based immunosuppressions can cause hypomagnesemia, and it is a documented fact that 25% of patients treated on cyclosporin, treated with cyclosporin, can have hypomagnesemia. So, and even the diuretic therapy can cause hypomagnesemia. So, hypomagnesemia causes what? It causes muscle weakness, hypokalemia, hypocalcemia, hyperlipidemia. So one has to supplement magnesium sulfate initially with which is the dose is 4 grams IV, and even now I think the oral magnesium sulfate is also available nowadays. Now, classical sign of severe hypomagnesemia is hypocalcemia. So, and hypocalcemia cannot be resolved unless magnesium deficiency has been corrected. So, magnesium, you must, along with whenever you get the serum potassium and sodium done, do also get the magnesium levels done for your patients regularly. Now, talking about anemia, well, anemia cannot be corrected with diet, but it is a risk factor for cardiovascular disease, graft function, graft failure, and all-cause mortality. And 30% of our KTRs can actually be anemic, and the main causes are impaired graft function, immunosuppression induced bone marrow suppression, inflammation, antihypertensive medication like ACE inhibitors and ARBs. And the nutritional causes are the nutrient deficiencies like iron, folic acid, B12. But there's little evidence that dietary intervention alone can correct anemia. So the recommendations are the patient should be put on balanced, adequate. He should be taking balanced and adequate diet containing iron, folate, and B12, and the sources are green leafy vegetables, apple, poultry. And KDOKI guidelines recommend oral iron supplementation for these patients. And so this is a picture showing you whole grain cereals, fresh fruits, which should be given to your patients. And remember that hemoglobin will build up gradually in these patients. Now, moving on to hyperhomocystinemia, according to AHA, American Heart Association, there are no recommendations for supplementing vitamins to correct hyperhomocystinemia, and that's folic acid. But in our patients, we do have problems with hyperkalemia. So, and even after transplant, as I said, if the patient has tacrolimus or cyclosporin-induced hyperkalemia, you're going to restrict vegetables and fruits. So therefore, folic acid will have to be supplemented to these patients. And the other source is whole grain cereals are really, really rich in vitamin B complex. So the patient should take these. Now, hypertension is associated with the CVD and the cry and acute rejection. So therefore, the target blood pressure for our patients is, according to the guidelines, less than 130 by 80 millimeters of mercury. But we normally practice less than, a target blood pressure of 120 by 80 for our patients. And if the patient is a child, then it should be less than 90th percentile for sex, age, and height. Now, high salt intake decreases anti-albuminuric effect of the anti-RAS therapy and antihypertensive pharmacological intervention. So therefore, one has to be very careful so as not to allow the patient to take high salt intake. Now, high salt intake results in decreased graft survival and left ventricular hypertrophy, an independent risk factor for heart failure and death in renal transplant recipients. Therefore, restriction of dietary sodium chloride to a maximum of 5 grams per day for an adult should be a priority, not only to combat hypertension, but also to reduce proteinuria, which decreases during low salt diet, probably following blood pressure reduction. So the guidelines say for stable hypertensive kidney transplant recipients, they should be advised to restrict sodium intake to 80 to 100 mmol per day and saturated fatty acids to less than 7%. And so far, there are no large-scale trials to determine whether nutritional intervention alone can be effective in managing hypertension in KTRs. Now, AHA also recommends DASH diet for controlling blood pressure, which includes 5 to 9 servings of a variety of fruits and vegetables, 2 to 4 servings of cereals and grain products, including whole grains, low-fat dairy products, poultry, fish like salmon, mackerel, herring, albacore, and tuna, and nuts as meals and snacks, reduce fat, red meat, sweets, and sugar-containing beverages. Now, our patients do have dyslipidemia, which is and the prevalence is about 16 to 60%, and the causes are metabolic effect of steroids and cyclosporin, tacrolimus, sirolimus, renal dysfunction, proteinuria, increased body weight, inappropriate food intake, history of nephrotic syndrome with hyperlipidemia, hypertension, and altered lipid metabolism during dialysis period. So this is, the underlying mechanism of hyperlipidemia, like glucocorticoid steroid therapy induces insulin resistance in peripheral tissues, which leads to impaired synthesis of lipoprotein lipase, and which leads to persistent response of liver to hyperinsulinemia, and hence there is enhanced lipid synthesis. And also cyclosporin therapy interferes with the feedback mechanisms regulating LDL cholesterol synthesis, alters binding kinetics of LDL and its receptor, inhibits 26-hydroxylase, and there's reduction in synthesis of bile salts from cholesterol, and therefore decreased hepatic lipase and lipoprotein lipase, and decreased conversion of VLDL to ideal and LDL. So so it's been recommended that tacrolimus instead of cyclosporine can be a good approach for treating hypercholesterolemia in our patients. Now, dyslipidemia contributes to increased cardiovascular morbidity, and lipid management should be according to KDOQI recommendations, and statins can be given to our patients, which we do normally. And also think about careful but more rapid tapering of steroids. That would be great help. Now, management of dyslipidemia and fiber intake I've already talked about in my previous lecture, so I'm not going to touch upon this. I'll save time. But I will say that fatty acid intake can be modified by substituting canola oil. As it includes both it has both omega-3 fatty acids and monosaturated fatty acids for vegetable oils. The National Institute of Nutrition recommends use of rice bran oil or ground nut oil along with either mustard oil or soybean oil or sunflower oil. So one should try and use a combination of oil and not stick to just one oil. Okay. Now, post-transplant hyperglycemia, which is very, very important, that is NODAT, which develops in non-diabetic patients due to corticosteroid and CNI therapy. But it has been seen that in 70% of the patients within 1 year, NODAT resolves with just dietary restrictions, and as the immunosuppressive therapy is titrated. So the guidelines recommend screening all non-diabetic KTRs for NODAT after starting or substantially increasing the dose of CNIs and mTORs or corticosteroids. And so you have to monitor the fasting plasma glucose, oral glucose tolerance testing at least weekly for 4 weeks, and HbA1c every 3 months for 1 year and annually thereafter. And the target HbA1c should be less than 7%, but one should not try to touch 6% because if the patient is having hypoglycemic reactions. So in that case, one should not target a very low HbA1c. Now, the recommendation for NODAT are the same as what Dr. Vijay Lakshmi Bhatia told yesterday: limit carbohydrate to 50 to 60%, limit fat intake. So I'm not going into this. Insulin therapy is something that is important. And the thing that I have to talk about here is you must tell your patients to bring with them the blood glucose and the blood pressure recording or at every clinic visit when they make, because that way you'll be able to make out how the patient is doing at home, and reduce dose of insulin and oral agents as required to avoid hypoglycemia. And also, I'm not going to talk about this, how many meals to be taken, because I think she's already covered this up. So all I have to say is restrict use of artificial sweeteners, as they can cause neuropathy in long run. And the intervention which can actually increase insulin sensitivity are weight loss, exercise, reduced protein intake, anti-inflammatory agents like curcumin, haldi, turmeric that we take every day. Curcumin, the active ingredient of turmeric is curcumin, the yellow part, which has anti-inflammatory agents. So you can encourage your patients to do that, because it's been shown to have, it has shown to be nephroprotective, right, and renoprotective. And vitamin D, insulin sensitizer, antioxidants, metabolic acidosis, and magnesium deficiency. So let's move on to post-transplant obesity. Now, why do kidney transplant recipients gain weight or become obese? And do we have to control weight? Well, weight gain occurs in patients who were obese and patients who were not obese before transplant, in both the types, who were obese and who were not obese. So factors contributing to post-transplant weight gain and obesity, they fall in 3 phases: the pre, the peri, and the post-transplant period. So the pre-transplant period is obesity, is pre-existing obesity and poor functional status of the patient, and the peri-transplant obesity is weight gain. I'm not talking about obesity, I'm talking about weight gain. Is because of positive fluid balance. So therefore, correction of fluid and electrolyte imbalance is required. Hyperphosphatemia due to remaining elevated FGF23. And in the post-transplant period, the immunological factors like inappropriate dietary intake, that is very high calorie intake and milk products, and decreased or reduced physical activity and non-immunological factors like immunosuppressive medication. So all these things lead to post-transplant weight gain or obesity. Now, rapid post-transplant weight gain occurs in patients who have lost a lot of weight in the pre-transplant period. So remember this. So the weight gain is because of reversion of the uremic state, which increases appetite. Liberal intake of food, steroids increase appetite, causing weight gain. High dose steroids during allograft rejection episodes, post-transplant hypoglycemia and diabetes, and decreased physical activity due to comorbidities such as coronary artery disease, CVA, peripheral arterial disease, and prolonged recovery from dialysis fatigue. And here, if you have a look at this figure is showing you that the maximum weight gain is in a patient who had a pre-transplant BMI of less than 20 kilograms per meter square. So this is the patient who lost maximum weight. So he is going to regain weight. He wants to get back to his original weight, right? So we shouldn't be so scared of the patient gaining weight, but then we should be scared once he has attained the previous weight gain, of course not the obese one. So then we should start titrating his dietary intake, titrating his dietary intake. And here you can see obesity is one of the predictors of vascular stiffness. So this is another reason why we should not allow our patients to become obese. Excessive nutritional status in transplanted patients is associated with significantly increased vascular resistance. That is, this is the resistance index and the pulsatility index in the obese. Then there are greater chances of mismatch in recipient donor size and hence nephron underdosing, that is hyperfiltration, and impaired bioavailability of immunosuppressive drugs, delayed graft function, delayed and graft dysfunction, obesity, mediated hyperlipidemia, hyperglycemia, hypertension, inflammation, and chronic allograft nephropathy. These are all the implications of weight gain. Now, post-transplant weight gain is a major trigger for poor cardiometabolic profile in the renal transplant recipients, including post-transplant diabetes and the metabolic syndrome. Now, this study has shown that when you have steroid sparing regime, the KTRs, they do not gain as much weight. So we should try and taper steroids as fast as possible. And this study is also showing you the same thing. The patients who were on steroid sparing regime, they gained weight minimum, and those who had rejection episodes, they gained weight, they had maximum weight gain. And we know that by 1 year of transplant, 60% of patients gain weight by 10% or more. But what are the recommendations for obesity? Well, the international bodies like UK Renal Association, Canadian Society of Nephrology, international guidelines, kidney disease outcome quality, they have absolutely no recommendations at all for obesity and intervention. But the KDOQI guidelines say, although they don't have any recommendations, but whatever applies on general population can be applied on these patients. Now, European best practice guidelines recommend obesity, which is BMI more than 30, and weight gain are associated with increased prevalence of cardiovascular disease after transplantation. Therefore, appropriate dietary and lifestyle measures should be recommended to these patients. But there are no randomized controlled trials on this. Whatever the small uncontrolled trials on KTRs are on diet and other behavioral modifications, they say that diet and other behavioral modifications are safe and help reduce weight gain over short term. And there is no evidence that any one diet is more effective than any other diet. A reasonable goal for our patient is to create a calorie deficit. Those who are really obese, for them it is, you have to create a calorie deficit of 500 to 1000 kilocalories per day. I would say 500 to 600 kilocalories, but the recommendation that the papers say between 1000 to 1200 for kilocalories per day for women and 1200 to 1500 kilocalories for men. Well, I think that is a bit too drastic. And increased physical activity may help to sustain weight reduction and reduce CVD risk independent of weight reduction. And here you can see there are some studies which have shown that nutritional intervention has resulted in loss of weight up to the tune of 5 kilograms, and in some it is 2.6, in some it is 3 kilograms, but it is effective, and it also brings down the energy intake of the patient, the cholesterol intake, the total lipids, the saturated, the monounsaturated, and the unsaturated fatty acids, it's all come down. So overall, you can see there's a 30% energy restriction with respect to estimated energy expenditure with the nutritional intervention. So the conclusion here is that monthly individualized intensive dietary instructions from dietitians are important, and the follow-up should be done by a dietitian. So a mean restriction of about 600 kilocalories per day should produce body weight loss, even while energy expenditure decreases to some extent when dieting. And since the evidence of specific diets for weight loss in these patients is scant, one reasonable approach is to start them with 25 kilocalories per kg body weight per day. Okay, and glucocorticoids do increase weight, we know it, and body fat even during diet restriction. So you should try and resolve this problem. This is something that the clinicians should think of, and reduced level of physical activity in patients should be discouraged at any cost. And here is an overview of risk factors and treatment goals for CVD. This is KDIGO recommendation that you have to reduce risk for NODAT, hypertension, dyslipidemia, and obesity. And here are the recommendations for body composition, and then cardio-metabolic risk factors, glucose metabolism, and renal function. So these all things have to be addressed. Now, lastly, I'm going to talk to you about the food safety. And that is during early post-transplant period and in periods of acute illness, the likelihood of foodborne infection is high due to significant suppression of the immune system. So foodborne illnesses often present with flu-like symptoms like nausea, vomiting, diarrhea, and fever. And so one should try educate our patients on, abstaining from untreated or contaminated water. You should preferably take boiled water, unpasteurized milk, raw uncooked meat, poultry, or shellfish, or uncooked vegetables or not properly washed vegetables. These should all be avoided. And the pathogens, I'm not getting into the symptoms, the pathogens which cause foodborne illnesses. It's like Campylobacter, Cryptosporidium, Listeria, E. coli, noroviruses, Salmonella, Toxoplasma gondii, and Vibrio. So the take-home message of my talk is advise boiled drinking water to the patients, maintain hygiene, wash vegetables thoroughly, eat freshly cooked food. In case the skin of the fruit is oily, wash it with warm water. Fish and chicken can be given twice a week to the patient. Patients must avoid unpasteurized raw milk to prevent foodborne illnesses. Abstain from raw or uncooked meat, poultry, or shellfish. Advise not to add extra salt to the food. Advise 1 level teaspoon of salt to keep a good control of blood pressure. Remove salt shaker from the table. Advise low-fat dairy products. Remove cream. They should advise them to remove cream from milk. Advise egg white. Egg yolk can be taken twice a week or thrice a week, provided the patient is not having dyslipidemia. Patients on tacrolimus should not take grapefruit juices, and medications should be taken, especially the immunosuppressive medication should be taken empty stomach, at least half an hour before meals for better bioavailability of the drug. And a correct dietary approach, we know now very well, can preserve graft, delay progression of both chronic allograft nephropathy and of cardiovascular disease. So monitor nutritional status regularly. Good control of blood pressure and blood glucose is imperative. Prevent obesity and bone mineral disease. Advise lifestyle changes of exercising 30 minutes, at least 5 times a week of moderate intensity. Physical activities such as brisk walking, cycling, and gentle aerobics at least 5 times a week will be of a great help. And thank you for your attention.